Good afternoon, everyone. We're now live.
Good afternoon, everyone. I'm Deb DeVoe, and welcome to this afternoon's board meeting. Welcome to my fellow commissioners, to the HPC team that's in the room here, and to the public that's joining us through the YouTube live stream. We have several important topics to cover today. First, we're going to hear policy recommendations on the pediatric provider market trends in Massachusetts. We originally presented the report at the December HPC board meeting, but look forward to recommendations and the discussion. We'll finish our 2023 cost trends report previews with a staff presentation of the performance dashboard and a discussion about the 2023 policy recommendations, which we're preparing. We'll also provide a status update on the Mass General Brigham Performance Improvement Plan. This is the first status update. And then our executive director, David Saltz, will close out the public meeting with his report, during which we'll take a vote to approve the HPC's FY 2024 operating budget. And then we'll vote to enter an executive session for the final hour of the board meeting. So the first order of business is to review the minutes from our last board meeting on June 7th, 2023. And I'll turn it over to our Acting Chief of Staff, Hannah Cohen.
Thank you. All right, so can I get a motion to approve the minutes?
So moved.
Thank you. And a second? Thank you.
Second.
Chair DeVoe, I'll start with you.
Approved.
Vice Chair Cohen,
Approved.
Commissioner Castiel,
Approved.
Commissioner Haupt,
Approved.
Commissioner Master Giovanni,
Approved.
and Commissioner Song.
Approved.
Thank you. Oh, and Barbara is joining us right now.
Oh, great.
Commissioner Blakeney, can I get a vote from you whether to approve the minutes from June 7th?
Yes, I'm sorry, approve. I'm just getting into the call. My
Thank you.
apologies.
Thank you. Apologize for asking for a vote the second that you entered the meeting.
Okay.
And with that, the minutes are approved. We can move forward.
Great. Thank you so much. And I'll turn it over to David Saltz to introduce the pediatric market top.
Great. Good afternoon. Thank you, Chair DeVoe and commissioners. Welcome to this summer meeting of the Health Policy Commission Board. We are pleased to be streaming live from the Stuart H. Altman Conference Center at 50 Milk Street. We are testing our new technology capabilities here for a hybrid board meeting. We have a few commissioners here in person this morning, as well as staff and fellows from the HPC here watching today's event live. So this is a milestone for us in terms of attempting to try something a little bit different. We'll see how it goes and hopefully no technology challenges along the way. So as the chair mentioned, a lot of big topics for today. We're going to start with returning to a topic that we had previously discussed at a board meeting last year, which is around the trends of pediatric consolidation in Massachusetts. So this white paper was really inspired by some of the trends that we've been seeing over the years in terms of closures of certain pediatric units, as well as expansions for other pediatric providers in Massachusetts. And we felt it was worthwhile to really put in place, a data-driven analysis of all of these trends. We presented a lot of the findings for you at the previous board meeting. I do want to highlight some of those key findings and data points again as we go into this conversation. But really what I'm hoping to hear from board members today is any additional thoughts as we kind of put the final touches on this paper, points that you think are important to include, and also to talk about the policy implications of our findings. We do want to include a section in the report at the end that would include some policy considerations for the audience reading this report about what we make of some of these trends and what might be some potential policy solutions to mitigate some potential negative impacts, as well as maximize some potential positive impacts. So we have prepared and we circulated to board members prior to this meeting a draft of the report, as well as some of those draft policy consideration areas. But really today, hoping to get your feedback on those for discussion. Following today's meeting, then we will take your comments and input. We'll prepare a final report. And to the public, we hope to release that final report before the end of the month. So with that, to kick us off, I'm happy to turn it over to Sasha Hayes-Rusnov, who's been leading this work. This work has spanned multiple different team members and teams. Really appreciate the cross-agency effort on this report. But Sasha will first begin with just a summary of the key findings and the context for which we're issuing this report. So why don't you take it away, Sasha?
Yeah, thank you, David. Good afternoon, commissioners. Apologies that I can't be present in person today. David, I think that you really covered a lot of the sort of setup points that I wanted to highlight before digging into the key findings. One thing that I will mention is, as has been said, our initial presentation on this work was in December. Following that presentation, we had an opportunity to discuss those findings and the presentation with some of the major stakeholders in this space, both provider entities as well as some payers and representatives of consumer groups. So had a chance to sort of talk through their takeaways and incorporate some of those into our thinking about the policy brief that we've been working on. We've also refined some of our analyses and as David mentioned, drafted some recommendations on policy changes based on our findings. So I want to move right on to the next slide, I think, and review some of the key takeaways. Again, we covered many of these in December, but want to refresh folks' memories on these. So just to start off, as a reminder, we've generally scoped our analyses to be thinking about care provided to patients under 18 years of age in the Commonwealth, but excluding labor and delivery services. And also focusing specifically on care for Massachusetts residents. Our largest pediatric provider organizations obviously serve patients from throughout New England, the country, and indeed the world. But we've really focused in our report on market dynamics, costs, and accessibility for Massachusetts residents. And so the first key takeaway from our work is that the total volume of pediatric care, especially inpatient care, has been decreasing over the last decade. We've been, as we've been looking at inpatient care generally, as you know, that's been primarily driven by declining commercial patient volume. And many hospitals have responded by reducing pediatric capacity, especially community hospitals. And at the same time, as David mentioned, some of the largest providers of pediatric care have been expanding services. And the two largest in the Commonwealth are Mass General Brigham, anchored by MGH's Mass General for Children, and Children's Medical Center Corporation, the parent organization of Boston Children's Hospital. And those two largest provider organizations now account for a majority of pediatric hospital care for Massachusetts residents, and they're also among the largest pediatric physician networks. Consolidation across all types of pediatric care, we found, has been increasing over time. And the recent market changes, including the closure of pediatric beds at Tufts Medical Center, are only likely to continue that trend that we've seen over the last decade. As we've identified before, that trend of consolidation towards larger and more specialized systems is one that we've been seeing for pediatric services in other markets nationwide. And we also looked closely at prices for pediatric care and identified that those largest pediatric provider organizations tend to get higher prices than others, especially for hospital services. The next slide carries on with some of the implications of consolidation that we're describing. First, we recognize that consolidation of pediatric care at these regional specialty provider organizations does have some benefits. It can create economies of scale for the providers, And it ensures that when patients go to one of those pediatric provider sites, that site has the right equipment and clinicians specialized to treat a pediatric patient. It also means that clinicians at those larger providers see sufficient patient volume to build and maintain their clinical competence, which could otherwise be challenging when you're talking about very low volume specialties where the number of children to begin with that would be coming through is relatively low. And MGB and Children's also have very large financial resources compared to other Massachusetts provider organizations, and they can use those resources to improve access, especially to specialized care. However, regionalization can also have negative impacts. Patients outside of major metro areas have had to travel further for hospital care over time, even for common lower acuity services, as community hospitals have reduced their pediatric capacity. Longer travel is associated with longer lengths of stay and higher readmission rates for children. And travel also poses greater burdens for caregivers who have to take more time off of work, may have to pay for parking, food, and even lodging in the city when they bring their children for care. And concentration at the largest provider organizations increases spending at a broader level as well, as those largest providers, as we've said, tend to have higher prices. The level of existing consolidation and the specialized nature of the services make it unlikely that competitive forces are going to meaningfully constrain prices for pediatric services. And the shrinking options for where patients can get pediatric care mean the demand side incentives are likely to be less effective and indeed just more burdensome for patients and their families. With regard to shrinking options, the next slide, you may remember, shows changes to pediatric services that we're aware of through formal notices by providers to the state. On the left side, again, is a recap of the over 200 licensed pediatric beds that have been formally closed since 2017. Again, in most cases, these hospitals indicated that not all the beds were being used at the time necessarily. Some licensed but not staffed, but all of these represent reductions in total pediatric capacity. On the right side, you see a summary of expansions and acquisitions by Children's. That includes most recently, as I'm sure you're all aware, Children's recently finalized its acquisition of Franciscan Children's Hospital on July 1st, and Children's has articulated a plan to significantly expand Franciscan's, and that followed from significant expansion of the main Longwood campus that started to open last year, and proposed expansions of ambulatory sites that were approved by the Department of Public Health at the end of last year. It's our understanding that MGH has also added several pediatric beds over this time period. And in the middle, there's also the clinical affiliations between other provider systems and the networks of Children's, MGB, as well as Tufts Medicine. And that's led to a situation where those three systems staff the pediatric departments at most Eastern Massachusetts hospitals. The hospitals that those three systems own accounted for 65% of all commercial pediatric discharges for Massachusetts residents in 2019. But if you add in their clinical affiliates, departments that they staff, those three provider orgs, Children's, MGB, and Tufts, accounted for over 80% of Massachusetts statewide commercial pediatric discharges. And the next slide has, again, a reminder of the price implications for this. This is inpatient prices. We cover outpatient hospital prices and physician prices as well in the brief. The graph shows prices relative to the average price across these hospitals. These prices are adjusted for patient acuity, and the size of the bubbles corresponds to hospital volume. And as you can see, there's substantial price variation, and the largest providers also tend to receive the highest prices, again, even after you adjust for patient acuity. And as a higher proportion of commercial patients use those providers over time, we would expect spending on pediatric care to increase. So on the next slide, that's sort of a preview of the major topics in the policy brief. As David said, we want to open this up for discussion. Very interested in feedback, commissioners, especially on the policy recommendations or other priorities here. We can, I guess, up to you whether you want to go on to the policy recs first, or if we should pause for discussion now.
Sasha, I think it's let's continue, and we have put together. This is kind of where we left the discussion in December, and so based on the conversation in December and many of the stakeholder conversations since then, we put together a set of draft policy considerations. So let's go through that, and then we'll return to this slide and open it up for conversation, because I want to get commissioners' reactions to what we had prepared.
Yeah, great. And I want to go back to something that you said earlier, David, which is that the goal, as we've been thinking about it, is to recognize the current state of consolidation in this space and consider where we go from here, to think about how we can promote the benefits of regionalization that's already happened and is likely to continue, while also ensuring access to services that are needed in the community and safeguarding against higher healthcare spending, affordability barriers for patients, and inequitable distribution across geographies and across different demographic groups. So in thinking about how to address those questions, the next slide starts with the policy recommendations that we've thought of. These are intended, I'll say, to align with recommendations we've made in the cost trends reports. So some of these are likely to feel familiar. First, in order to be able to best support community access to needed services, we need to actually engage communities, provider orgs, and other stakeholders to build a consensus around expectations for what pediatric care can be safely and effectively provided in the community versus what care really ought to or can be regionalized. That definition is likely to change over time as different capabilities and technology allow for different capacity. But that conversation is sort of foundational into how we assess appropriate access to services at the community level versus the regional level, and the steps that we take based on that assessment. Second, we have opportunities to enhance data collection that's going to help us address health disparities for children. Our starting point here is the recommendations of the Health Equity Technical Advisory Group from the QMAP. They provided some standards for data collection that ought to be adopted for all the current data reporting schemes. The state could also consider new data collection efforts around health outcomes for children that incorporate data that would allow us to better assess variation in health outcomes for kids based on demographics and other social determinants of health. Third item here is, given the regionalization of care, considering ways to better use information technology to support pediatric services outside of the urban centers, both in terms of providing access to specialized services, as well as allowing, again, clinicians to see sufficient patient volume that they're able to effectively practice in their specialties, even when patient volumes have been declining. Next slide.
Before we leave the slide, can I ask I have one question and one comment. The first is on number one. I wanted to think a little bit, and maybe I'm conflating two prior meetings conversations, but I remember a slide, I think it was the last meeting, where it looked at the utilization of ambulatory surgery across the country, and we ranked like towards the bottom. Ambulatory surgery center access. I'm probably maybe recalling it wrong, and wondering if that connected to this issue, and does that further limit access to pediatric care, since so much of kid care is, particularly operative kid care, unless it's a very serious situation, is done on an ambulatory basis. That's the first question. And then the comment is, from a regional health equity standpoint, I think you are absolutely correct on the focus of beds, that it should be done in places where there's, I think the standard is like you have to have at least 200 beds to be doing this at scale or something. But I was thinking a little bit about the fact that, and when in full disclosure, when I served at Boston Medical Center, we really wrestled with, how much pediatrics should we do, and landed on the fact that as a Medicaid provider that we needed to stay in the business. But I'll point to a kind of care that does not require a hospital bed, but often requires the kinds of specialists you see in hospitals. So developmental pediatric and neuropsychiatric testing for kids, and autism evaluations, there's a better term for it, where the waiting lists are heartbreakingly long. Finding a Spanish-speaking provider is almost impossible. At some point, maybe there'll be a technology fix, but these assessments are very hard to do. In some parts of our state, the private pay market picks up that gap, but for the patients that we served at BMC, or the people who are getting this testing done in the neurodevelopmental clinic at Boston Children's Hospital, they are likely to be Mass Health clients. They don't have access, and people are waiting years for, and we know early intervention is important. So I think the focus on beds is appropriate and probably the right answer. I just want to flag as a policy question for us to review. There's things around the beds that our patients need that is going to be harder for them to get. So sorry, that was a longer speech than I intended, but I kind of got ahead of steam. But
no, by no means. Those were excellent points, and especially I completely agree that while beds in some ways are the easiest to track in terms of access, and admit that that's part of the reason that we have a great deal of data on them. Those other services that, as you say, tend to be concentrated around hospitals but don't necessarily require a hospital setting, it's a hope that those are amenable to some of the access solutions that we're thinking about, but there are also restrictions, as you say, based on workforce, for example.
Yeah, and developmental pediatrics, so that fellowships never get filled.
Yeah.
So we should, and also people and the kinds of patients they care for tend to need to be in the hospital a lot. So getting this testing done on a kid who's more well or not as sick is almost impossible outside of an academic medicine setting. So just something to think about. I think technology will help, and there might be other ways to do it, and maybe we can have other trained professionals do most of the test and do some kind of triage thing. But the beds are really important, and I think we're on the right hunt there. I just didn't want to lose that other thought. Thank you.
No, absolutely.
And thank you, Madam Secretary. I just wanted to validate that you did remember correctly the information about ambulatory surgery centers, of us having among the lower per capita count of ambulatory surgery centers. And so that is also a topic that we're going to be doing a little bit of a deeper dive in terms of understanding where those ASCs are located within the Commonwealth, what types of services they tend to provide to what types of populations. So that is ongoing work. And just to add to the other point, we also issued a report last year around children with medical complexity that really talked about kind of the very complex and interrelationship of social health needs for a segment of pediatric patients. And just the tremendous amounts of family and supports that need to go into care for those patients. And so I think we should think about how we can bring in some of those facts into this white paper as appropriate.
Thank you. Thanks.
Cover the last two major areas of recommendations that we have here. For given the price variation that I described earlier, it's our recommendation the legislature should consider action to constrain price growth for the highest price providers. As you know, this has been a component of our cost trends recommendations for a couple of years running. This is not just limited to pediatric providers, but we see that in pediatrics, we have the same sort of price disparities that make this an important component of recommendations for the system. There are also consumer-focused steps to addressing affordability that would be particularly meaningful in the pediatric space. Those include limiting hospital outpatient facility fee billing, promoting alternatives to high deductible plans that are unlikely to drive patient choice in a market where the options are relatively limited, as well as public and private investment in mitigating the cost of transportation and investment in transportation options to help patients reach those regional care hubs when they need to do so. And then finally, fifth here, the state and other payers should consider how best to incentivize the provision of pediatric care in community settings. There are options to explore here, frankly, including subcapitation, perhaps focused rate enhancements for specific services or specific geographies where community-based services are lacking or need particular support. And perhaps special funding mechanisms where we recognize, for example, those workforce development issues that you brought up, Madam Secretary, or for technology implementation or other focus initiatives for specific access areas. So those are broadly the 5 areas of recommendations that we've drafted for the policy brief, and maybe we can tap back a couple of slides, and would love to open it up for any commissioner thoughts about additional ways in which we can think about again supporting the benefits of a regionalized model while ensuring appropriate access and limiting spending and affordability barriers.
Sasha, I'll jump in. I think the first point that you raised about defining and building consensus around a set of lower acuity pediatric care is probably the key here, particularly because it impacts not only where the child is getting care, but the impact that it has on the family and caregivers. I'm curious, this is not and you said in your presentation that this is not a Massachusetts phenomenon. This is something that's happening across the country. And do we have any knowledge of what other states have done in this regard in terms of sort of minimal capacity that they have established across geographies within those states?
That's a great question, and I have to admit that we haven't dug into other states' policy solutions around this issue as yet. Certainly, we've seen the similar market dynamics, but I'm not aware of specific work that other states have been doing. But that's definitely a great next step to dig into.
I'd like to just say that with respect to regionalization, that I think it's a good idea if we don't have the mechanisms otherwise. I think my main concern is when we're talking about equity, the families that have to drive, all the things that we talk about. And I know it's not part of what we're voting on, but I am concerned about that process and sort of that support of the family. And I think that if there is a higher cost because we're doing that, I think it's important. I think everything else that we've regionalized, whether we talk about behavioral health, that people are going out of the area to be hospitalized, certainly is a detriment to the society. And in particular, people of color is the main people that are suffering through that process. So I don't know what's been put in place in these situations, but that's my main concern, that I worry about that.
Sasha, I just wanted to comment on what an excellent report this was and how thorough it was, in the fact that you could tell that a lot of stakeholders had contributed to the thoughtfulness and the recommendation. Just a couple of things I wanted to comment on, because a lot of the data seems to run through 2019. According to Mass Health Quality Partners, we're seeing a decline in actual pediatricians within the state, and I don't see that addressed within the report. We're finding families are having a hard time finding appointments for their children, which can lead to things like inability to enroll them in daycare because they don't have vaccines, they don't have annual checkups, and there's a sort of a snowball effect that that happens when you can't actually access a provider. And along with the providers who do exist, a lot of them, especially the independent ones, are seeing a very high percentage of their caseload in the Medicaid space. And their reimbursement levels are not keeping up with expenses by any stretch of the imagination. And a pediatrician is also the frontline person in dealing with a child with a mental health issue. That's not the same as checking for a strep throat and involves a 45-minute visit. And my understanding is the reimbursements are not all that different based on the length of time the pediatrician is having to spend with the child for these really important diagnoses and treatment. And we all know that there's not enough mental health providers out there either for the pediatrics. The other thing that I wanted to comment on, which happened last fall and winter, was what I call the medical trifecta of the RSV, flu, and COVID convergence, where we saw these horrific news reports of children being turned away, being in waiting rooms, having to be flown to other states. The New York Times did an incredibly gut-wrenching video on what was actually transpiring during this period of time. And I think that really showed the cracks in our model here in Massachusetts and models throughout the country. So I feel really strongly that not only this is an equity issue, but this is protecting our children. And that's one of our primary responsibilities as adults, whether we have our own children or not. We're here making sure that they need to have the access to the care where parents can find it for them. So I think all of the points you brought up in the report are so very important. We obviously need to allow for care to take place in the right place, these less intensive services in the community, the more intensive services in the downtown specialty hospitals. There's no place I'd rather be as a parent if my children were very, very sick than to have access to the level of services we have here. But if somebody has an allergic reaction or an asthma attack in the middle of the night and they're not able to access pediatric services for something as critical as that, we have a problem. We really have a problem. So I think a lot of the recommendations are so very important. My biggest concern is, and I would say this to fellow board members and to staff here, is how do we make them actionable? Because I don't think we have a lot of time in some of these areas. These are really critical issues.
Thank you so much, Commissioner. And I just want to say, a great point on declining pediatricians, and we'll take a look and see what data we can incorporate into the final version of the report. And also recognize that that point you made on the RSV and seasonal surge last year is particularly well taken. There's a question, I think, as we've seen a decline, particularly in inpatient capacity, about how do we ensure that when we do have that kind of a surge, that there is an ability for additional sites to stand up capacity in the same way that there was sort of a network response to the COVID pandemic. But that's limited when community sites don't have any sort of pediatric capacity, and how do we preserve that option for surge capacity under these sorts of conditions is a great question.
And I'll just add, very well said, Sasha. I think the current moment context is important here too. And while I think we started this analysis kind of seeing a lot of these hospital closures, new affiliations, and then in some cases expansions, and that really kind of led us to be like, what is going on in this market? And the paper does kind of get into, again, kind of consolidation in outpatient services and the physician networks. But I think there's another topic that I think is really relevant to today, which is around pediatric primary care and what are the barriers that people are feeling right now in terms of being able to access care, as you said, Commissioner. So I think we need to at least, acknowledge that somewhere in the report, whether that's kind of in kind of the introduction to say, like, we understand that there are other dynamics that we need to look into. I think in the policy kind of implications, maybe we want to add something there that's around kind of our commitment at HPC to future work here, not just more research, but other activities. And so including something like that, I think, can help hold us accountable. as we've discussed, we are beginning a project on looking at the kind of primary care market, of which pediatric primary care is obviously a really important part. And so I've been talking to CHIA. They've been working with MHQP on the primary care dashboard. So I think there's a lot more we can and should be doing there to kind of get a pulse of what's happening right now in terms of access to care. So I really appreciate those comments. Barbara?
Thank you. And David, I want to build a little bit on what you just said, which is we can begin part of the process by looking at what's already in place in community. And by that, I mean what's happening at neighborhood health centers that have pediatric practices, or can we encourage pediatric practices, more of it in community centers. The second piece is what can we do in terms of being able to build in some degree of specialty evaluation in places where children gather. Can we do that in schools? Is it possible to set up clinics or to create programs, testing programs where we look to schools, we look to churches, we look to the YWCA, the YMCA? Where is it in the community that children gather, and what kind of partnerships can we build there to get into those communities, those kind of resources and those kind of evaluative tools? So I think if we think outside the box, we may be pleasantly surprised in terms of being able to bring services as close to the families and to the children as we can encourage. The closer we keep the needed tests in the community, the more often they'll be used, the earlier the child will be evaluated, and the earlier appropriate modalities of care can happen. Thank you.
Commissioner Cohen?
Yeah, I just want to pick up on David's point about focusing on pediatric primary care. We should also look at what the impact, if any, this consolidation has on the training of new pediatricians. So has the consolidation or the lack of the reduction in beds, hurt our ability to attract new residents in pediatrics, and also as Kate mentioned, the other specialty areas that are needed to do evaluations and so forth.
Great point.
Other comments or questions from commissioners? So one theme we're hearing through a number of the comments and observations is underscoring the second recommendation around understanding what is happening in the market now through data collection around affordability, around access, around the ability to attract residents and retain them, primary care, et cetera. So I think it'll be helpful to be more specific about exactly what enhancements we want to propose to data collection. I think Sasha's point is well taken, that we have focused more on beds because that's what we have good data on. But given the consolidation, it's going to be helpful to be specific about each of the points raised and the need to track and understand the evolution. Other comments or recommendations? Sasha or David, any last questions?
No, this has been a really wonderful conversation and discussion, and I think we have a little bit more work to do to wrap this paper up. And I think even beyond this paper, more work to be done. And I will offer, just as an open question to commissioners, either you can respond now or reach out to me later. This was a policy brief that really kind of organically came from what we were seeing in terms of trends in the marketplace. Are there other service lines or other categories of service that you think would also be ripe for this type of a little bit of a deep dive, where we really spend some time going into the data to understand both market trends and their implications on affordability, access, and equity? This was, our one look at a very big pie, and so I think we are honing our capabilities to do this types of assessments for other types of services as well.
Can I just add one?
Yes,
thing?
please.
And maybe this is redundant, but are we doing a special study on pediatric mental health or access or no?
So we have started a broad scope of a report on primary care. And so that includes a lot of different things. We've mentioned that we can't talk about primary care without talking about mental health and behavioral health. So all of that is still in scope and ripe to put on the table.
Yeah, because I think pediatric mental health is just a huge, there's a huge shortage of providers there. It's beyond crisis, I think, at this point, so.
And tremendous need.
Yeah.
Thank you.
Thank you all so much.
Good,
Looking forward
thank
to
you.
bringing this forward.
Thanks so much. Our next topic is around the 2023 Healthcare Cost Trends Report, and I'll turn it over to David to introduce the topic.
Great, thank you. So pleased to present to you today, commissioners, the final major piece of our 2023 Healthcare Cost Trends Report. We have been splitting up these presentations over the last 6 months or so. This is our final big piece of the report that we wanted to preview for you and get your input on, which is our performance dashboard. Before I turn it over to Yua to walk through our findings and to orient commissioners to this dashboard, I'll just say after this conversation, we're going to pivot to talk a little bit about potential policy recommendation areas in the cost trends report. Then we will take all of that input. We will develop the final version of the report, circulate that to commissioners over the summer, and we'll be back in September with the final version of all of these materials for a voting consideration. So we are still in development here and ripe for comments and feedback. So with that, to walk us through our performance dashboard, I'll turn it over to Yua.
Hello. Good afternoon, commissioners. I am delighted to share the performance dashboard with you. So the dashboard is a feature we include in the cost trends report every year. And its purpose is really to assess the performance of the healthcare system, both in Massachusetts over time and how we compare to the US overall. And to do this, we include a wide range of metrics. And in more recent versions, we have added metrics on health equity and specifically took a look at disparities by income and race and ethnicity where possible. So in this year's version, we have included 25 metrics across different areas, and I will talk you through these. So on this first slide, we have metrics on health equity and affordability. So on affordability, we have metrics such as individuals who face high out-of-pocket spending, share of total compensation devoted to healthcare, adults who reported wanting to see a doctor but couldn't afford to, uninsured rates, and some metrics on prevention, treatment, and outcomes. So this includes things like cancer screening and outcome-related measures such as infant mortality. So the two sets of numbers under the Massachusetts time trend show how we performed in the previous dashboard, and then under most recent, we have the most recent statistics for each one of these metrics, and then the icons show whether our performance is improving or stayed about the same or has worsened over time. So you can see for under health equity and affordability, the Massachusetts trends are pretty mixed. On some things, we're getting better. Those are in the green. On some things, we have stayed about the same. Those are in the yellow circles. And then for some things, we've gotten worse. And notably, for most of these metrics, Massachusetts is outperforming the US overall. You can see the icons all the way on the right were green for almost all of them except for one. And that is the second one, the share of total compensation devoted to healthcare for middle-class families. You can see within Massachusetts, the share has actually decreased slightly from the last reporting period, which is 2017 to 2019, but the level continues to be higher than US overall. And this is really striking because we know Massachusetts is one of the higher income states in the US. Yet for our middle class families, they continue to spend over 20% of all of their compensation on healthcare. And then moving on to the next slide, here we're showing that even though we are performing relatively well on average, we know that there are disparities. So on this slide, you're looking at some of the same metrics, but here we're breaking them down by income or race and ethnicity where we could. So again, this slide has a lot of numbers, so I want to walk through one of them just as an example to kind of orient you on how to read this. So the first measure here, it's individual under 65 with high out-of-pocket spending relative to their income. So for high income individuals, 1.5% of them reported facing high out-of-pocket spending relative to their income. But in contrast, 18% of low-income individuals reported having high out-of-pocket spending relative to their income. And this, we're not talking about insurance premium. We're talking about everything else people still have to spend despite having insurance. So the disparity there between the high and low income groups is about 17 percentage points. And that level of disparity puts Massachusetts number 19 in terms of our state ranking. And last time we had data for this particular metric, we were ranked number 9. So our ranking has gotten worse on this particular one. And you can see based on the color coding for all 4 of these, the Massachusetts state ranking has gotten worse for these. So I won't talk through all of these, but the second half of the table shows the disparity by race and ethnicity, one for infant mortality and the second one for premature death from treatable causes. So these are things, mostly causes death that could have been avoided with timely and more effective care, things like maternal mortality, appendicitis, certain types of cancer, and things like that. And you can see for both of these, there continue to be considerable disparities by race and ethnicity. Okay, moving on to the next slide. These are metrics related to efficient, high quality care delivery. So we're talking about readmission rates, overall ED utilization, behavioral health related ED utilization, avoidable ED utilization, preventable hospital admissions among Medicare beneficiaries, and the percent of inpatient discharges to institutional settings for post-acute care. And you can see in Massachusetts, most of these have either stayed about the same and gotten worse over time. And we are not performing well compared to the US. We have in fact performed worse than the US overall on all of these where we have data. In fact, the scorecard for state health system performance, which is the big report that the Commonwealth Fund puts out every year, and they include a couple of the metrics that our dashboard is based on. This year ranked Massachusetts 44th in the area of potentially avoidable hospital use and cost, which covers a lot of these topics that you're seeing here. And whereas we're ranking at the top, in fact, number 1 for most of all the other categories that they have looked at. So we have, I think, presented on most of these results in our June board meeting, and we'll have all of these available in the upcoming cross-runs report where people are able to kind of dig into these in more detail. On the last slide, we have metrics on benchmarking spending, value-based markets, as well as an alternative payment method. So the first 4 metrics are related to spending, and you can see here we're in the red, and this just reflects kind of the spending trends that we know from 2020 to 2021. The THC per capita has grown after a negative growth in 2021, has really come back up in 2020. A drop in 2020 has really come back up in 2021. In particular, the growth in commercial healthcare spending is even higher than the overall THC, and on that metric, where commercial spending in Massachusetts is growing much faster than the US overall. And the next two look at premium. The premium has grown both in the employer market as well as on the exchange, but notably the exchange rates on our connector has continued to be much lower than the ACA exchange market overall. And the last four metrics are related to value-based markets and APM. So here we looked at the percent of discharge in the top 5 provider networks. So that's kind of a metric on concentration, market concentration. And we also looked at the share of newborn deliveries in community hospitals, the share of commercial discharges from hospitals with a high relative price, and the total share of alternative payment methods across insurance types. And for all of these, we have stayed relatively stable over time. So that's a quick walkthrough on what we're including in dashboard. Happy to answer any questions.
Question, where does this dashboard go?
It's at the end of the cost trends report.
So it's not publicly available, or should it be? I mean, I'm sort of asking a rhetorical question.
Yes.
You have to know where to look to find it, right?
Right. It's at the bottom, but it's a lot of these are shown in more detail in
the whole report.
In the whole report. This is sort of, some of these are shown in the chart, in either the chart pack or the chapters, and then some of the metrics were just done for dashboard alone. And the dashboard itself, it's at the end of the cost trends report, right?
And is publicly available.
Right.
Mhm.
And can you say more about the affordability slide? Is it a self-reported, so when individuals are reporting high out-of-pocket spending relative to income, it's a self-reported metric?
Yeah, it's so this one is based on census data. And the definition of high is for high income individuals. Actually, it's on the slide. For high income individuals, it's if they're spending more than 10% of their income on healthcare, it's considered high. And then and high income individuals are defined as 400% of federal poverty levels. And then for low income individuals, if they're spending more than 5% of their total income on out-of-pocket spending, it's considered high. And that's low-income individuals are defined as 200% or less of federal poverty levels. And as I mentioned, when we say out-of-pocket spending, we're not talking about premium. We're talking about everything else that people, deductibles and co-pays, and that people still have to spend despite having insurance. And I believe this also doesn't account for over-the-counter medications that people pay for.
Thank you. Other questions from commissioners or comments?
Just ask again, when you have these disparities on that same slide that you're looking at, what do you do or what can we do in these situations when you see the disparity that we've been seeing for a long time? How can we go to the hospitals, to providers to be able to say, we need to bring those down? What can we do in that sense to hospitals, I guess, is what I'm asking. What requirements can we say to bring these numbers down? Is there penalty? Is there something that can happen in that sense? Because we just continue to see that.
Right. Yeah, that's a great point. I think from the research perspective, I mean, we're continuing to, I think the starting point is for us to at least to be able to dissect our data based on race, ethnicity, and that's something that our team has increasingly trying to do. But I think this is also a good segue into the next part of our board meeting, which is to talk about the policy recommendations, to actually talk about what we're going to do. Yeah. So I'll turn it back to David.
Well, I will just say, Commissioner, I think this is part of the motivation and the energy behind the Health Equity Compact and the Health Equity Summit, is where we have these known disparities. They are not getting better. I think you asked the absolute right and most appropriate next question is, what do we collectively do about that? And just to get back to the data for 1 second, that's the most important question. But you, in terms of our ability, and you've been working on these dashboards for a few different years. I noticed that we don't have kind of U.S. rankings for some of these race and ethnicity data comparisons. There's only a few. There's a couple where we're able to do the race and ethnicity disparity kind of cut. Do you see that improving? Is that another area where we should be striving to kind of have some of these that bifurcation or that look across all of these different metrics? And what are some of the challenges that often come into play there?
Yeah, I think lack of data certainly continues to be one of the challenges. I think so. A lot of the metrics shown here are from the Commonwealth Fund scorecard, as I mentioned. And I think over time, I'm seeing more and more data broken down by race and ethnicity over time. But again, to be able to do national comparisons, for example, we need to have good data on the national level, from all states by race and ethnicity. And I think and that level of data simply isn't available from a lot of places. So I think, things are improving, but again, we are kind of doing the best we can to show these data by income and by race and ethnicity as much as we can. But as you can see here, we're not able to do it for all of them.
Terrific. Very good to launch us into the discussion around recommendations.
Great. Thank you, Yua. And if commissioners have other comments or thoughts about how we display or distribute or provide context to the dashboard, we are very open to thoughts on that. I would mention one final piece in terms of how we've been able to evolve our display of the dashboard. Last year, for the first time, we put an interactive version of the dashboard on our website where people could actually click through and be able to toggle different options and be able to see all the notes about the sources of where each of these measures comes from, what the previous metric was. And so provided a little bit more level of depth for interested audiences to go that level deeper. So let's move on to slide 21, which is to begin the conversation today about the development of our cost trends report recommendations. So taking a step back, the cost trends report is our signature publication of the year. It is included in our statute as something that the HPC is required to produce every year, looking at trends in healthcare cost, quality, and access on an annual basis, and also to provide policy recommendations. So this report has been the report where we have typically put and sourced our main policy recommendations for the year for consideration by the legislature, the executive branch, market participants, other state agencies, as well as for our own work at the HPC. And so some of these recommendations are very closely tied to recommendations that we are seeking in terms of changing our enabling statute. Some of them are more around collective efforts that market participants and government could work on together, even absent legislative or statutory changes. So to begin this conversation today, I thought it was important to start with where our recommendations landed last year. So we had developed a set of 6 kind of core areas of focus that we included in last year's report. And this report, last year's report, was our 10th anniversary report. And I think we really highlighted in that set of recommendations a lot of our learning over the 10 years that the HPC has been in operation, what has worked, what could be improved upon, as well as our increasing knowledge of what other states are doing in many of these same areas, and opportunities for Massachusetts to learn and to be inspired by some of these other states, which candidly have gone further than Massachusetts in some of these topical areas. So I'm going to just start with just a very brief overview of what we did last year. There is a lot of detail. Commissioners, you know these recommendations, you've seen them many times. In fact, they were in some cases similar to the recommendations we had in the prior year as well in 2021. But these are the main areas of focus. But within each of these areas of focus, we had some subtopical areas. And so flipping to the next slide, our first recommendation was really around strengthening accountability under the healthcare cost growth benchmark and making some adjustments to the enabling statute that would allow for greater accountability and for us to be to evolve our approach, especially under the performance improvement plan process. So one, we recommended that we improve the metrics and the referral standards for monitoring healthcare spending growth through that process, and that we could consider differential referral standards that would take into account the differential position of providers in particular that are being referred to the HPC for review. Those different types of metrics may include relative payer mix, relative commercial pricing, market size or position. We do take account of all of those factors in our PIPS review process, but there are opportunities to move some of those metrics and considerations earlier into the process when CHIA is referring entities to us. Secondarily, here was an opportunity to enhance the enforcement tools of the performance improvement plan process. Right now, there is just a maximum $500,000 fine for non-compliance with the process. Other states have moved beyond that and have considered greater financial penalties, for example, entities that have been repeatedly going above the benchmark. And so opportunities to learn from other states. The second recommendation was around excessive provider pricing, where we saw provider pricing as a major driver of healthcare spending. A number of sub recommendations here around considering both price caps or price growth caps on the highest price providers that would allow for potential resources to be redirected to lower price providers and to reduce unwarranted price variation. We've made recommendations around limiting the facility fees or the additional fees that hospital outpatient departments can charge for services that are often commonly conducted in a physician's office at a lower price. Continued opportunities to expand the state's scrutiny of provider expansions in particular. And finally, a sub-recommendation around adopting a default out-of-network payment rate here in Massachusetts to simplify those instances where patients, providers, and health plans are facing out-of-network instances, and to not have to rely on the administrative process in the federal law, which is an independent dispute resolution process. The next slide, number 3, was really focused on pharmaceutical spending, which is a growing portion of our healthcare spending. This was the one area that had continued growth, even throughout the pandemic. Opportunities for enhanced transparency and oversight across the pharmaceutical sector, including pharmacy benefit managers, manufacturers, wholesalers, et cetera. An opportunity a recommendation to expand our drug pricing reviews, where currently we work in collaboration with Mass Health to potentially, we have not yet received a referral, but we continue to work with them and have the opportunity to review the pricing of drugs referred to us in relation to their value. That successful program, which has resulted in hundreds of millions of dollars in savings to Mass Health, could be expanded to other market segments. And finally, a recognition of the high out-of-pocket costs for certain high-value drugs that could be limited. The fourth recommendation was really focused on the health plans. And so here we wanted to ensure that as we're making policies that may in fact impact provider pricing, that any savings generated are really passed along to consumers and to employers and to other payers of the healthcare system. Sub-recommendation C here was an opportunity around reducing administrative complexity and providing greater relief to providers and patients who have to navigate our extremely complicated healthcare system, and other sub-recommendations around APMs. The fifth recommendation was on advancing health equity for all. Health equity is a topic that is intertwined into all of these recommendations, but nonetheless, we felt it valuable to have it stand alone. And some of the sub-recommendations here were around setting a health equity improvement target. So just as we were talking about before, Commissioner, not just to report on the disparities, but to actually set common standards or goals that we as a collective community could work towards to actually improve those disparities. Of course, efforts to address social determinants of health are important in these efforts. Use of payer-provider contracts, encouraging payer-provider contracts that will incentivize and reward providers that are focused on health equity improvements, following the leadership of Mass Health, and of course, an opportunity to improve data collection. And then finally, in the final bucket here, other important topics that we feel like are important to keep on our menu of policy recommendations, particularly around improving primary care and behavioral health care, with focused investments in primary care and behavioral health care, and a secondary sub-recommendation around improving access to behavioral health care services. And in particular, I think we highlighted increasing access to medication-assisted treatment for opioid use disorder. And then the final two here are around continuing to understand and investigate the increases in medical coding and efforts to reduce low-value care. So while we did consolidate down into 6 main topics, as you can see, there are a number of sub-recommendations that were included in last year's report. I did that at a very high level. I have my full report in front of me if we want to go and dive deeper into any one of these. But let's return to the slide at the beginning of the presentation, which is, this is a great place to just remind us of what these topical areas were, the 6 topical areas. And then actually, I'm sorry, Ellie, let's move forward to the discussion slide. So I'm going to pause here and I'm going to turn it back over to Chair DeVoe to help kick off this board conversation. And I started with last year's recommendations and want to start the conversation here too as well. Having reviewed these recommendations, would really love to hear from commissioners. Are there recommendations that you think should be reprioritized, either highlighted as more in our report? Are there recommendations that you think we should be updating or reframing or expanding, given increased knowledge that we may have from the last time that we worked on this report? And then finally, of course, are there other new policy priority areas that were not included in last year's report that are important that we highlight in this year's report? So I will open it up and turn it over to Chair DeVoe to help us reflect on last year and think about what our priorities for this year will be.
Thank you. Comments from commissioners?
Chair DeVoe, I have sort of 3 comments, and I wonder how we address them. The first is, do we have a point of view about service closures? We talked about it during the pediatric conversation. We're seeing, it's of great interest to the public and the legislature. So that's one area we might want to develop a point of view about, because there's more coming. The second point to that is, the overall economic health of the sector. We spend a lot of time focused on the cost of and the price challenges that we face, and that's appropriate and that's our mandate. But the consequence behind this, is that hospitals find themselves increasingly in financial challenges, which, by the way, fuel some of the service closure questions. And then the third one is, do we expand the continuum, much like we've done with pharmaceuticals, to look at, I think about long-term care, think about pre-hospital care, think about hospital at home. And I know flirted is probably not the right verb for a meeting like this, but we talk about these things in passing, but we don't really study them with the intensity that we look at pharma costs. Now, obviously, that's a big and important topic, and it's kind of where the money is. But I think there's something on the continuum of care, because increasingly it's not just provided in the hospital bed. Those would be 3 potential areas for us to consider for next year.
Yeah. And when you talk about the economic health of the sector, you mean considering our providing a report or an assessment and tracking the economic health of organizations or
Yeah, I don't think we need to track it because she tracks it. I mean, you can read that there's probably $1 billion in hospital losses this year across the state. You know, CHIA will report that. It might be a little bit late, but I don't know where FY23 is going to answer, but it'll be north of $500 million, I bet.
Yeah.
And so, and that's doesn't include nursing homes and other places, and the pressure to keep services open. And I mean,
you're really raising, is there a point of view that the HPC should articulate around that issue?
well, I think it should at least influence our thinking on the benchmark.
Yeah.
Because if the benchmark is working, but driving people out of business or closing services where we don't think they should be closed, I think we just have to think about that.
Thank you.
So I'll just jump in on this one and thank you, Madam Secretary, for your comments. And you highlighted one that
the most obstreperous commissioner award, but
oh, great.
who doesn't did it?
You highlighted an area that has been kind of on something that I've been thinking about too, which is on the first point around on closures, and I think even to the second point around kind of economic health, which is there an opportunity for us to reinvigorate what is sometimes called as kind of like health planning, but really understanding the distribution of resources within our healthcare system and being a little bit more proactive in terms of being able to identify both, areas that are at risk, service lines that are at risk, individual providers or health systems that may be at risk, and what those implications may be for cost, quality, and access and equity if we just kind of let the market continue to go forward. And I think oftentimes our tools can be quite reactive in terms of state oversight. And so I do see an opportunity for us to get a little bit more upstream and to be upstream in thinking about closures before they're, kind of on the front page of the Globe, and to be designing our policies in such a way that we're incentivizing the expansions that we want to see, where we know that we need expansions in areas like behavioral health, in areas like primary care. And to have that be a data-driven assessment that is being anchored by patient outcomes and differential patient outcomes. And so the sub-recommendation from last year was a little bit focused on provider expansions. And I would say I think there's an opportunity to maybe reshape that recommendation to talk both about expansions and closures and what opportunities might be there. And I think there's an interrelationship there with the economic health of the sector, so that maybe we're not, if we can think about speeding up our analysis of that, so we're not having to wait for a year after the fiscal year closes to get the audited financials to know, okay, someone's in real trouble here. Can, and I say this, the collective we, HPC maybe working with CHIA, thinking about what are the right metrics that we want to be monitoring in a more real-time basis. So those areas absolutely resonate with me. And in terms of kind of thinking about the increasing continuum of care and the shift out of the hospital to other settings of care, I think is a really important recommendation as well. Especially, and it interrelates with workforce issues. If we know we have workforce issues and in the hospitals, how can we move some of that care out of the hospital? We know we have high rates of avoidable hospitalization and ED visits. And so I think there's a good interrelationship there. So just wanted to share my immediate reflections, but thank you.
Thanks. I just want to make sure we don't get an A on our Latin homework.
Great. Other input about recommendations, Commissioner Cohen?
Yeah, I agree with the secretary in terms of thinking about the overall sort of health of the various components of our healthcare system. The financial industry does stress testing on a periodic basis. Obviously, with bank failures, they don't do as an adequate as adequate job as they could be, but it's something that we may want to think about in terms of really identifying those sectors, whether it be long-term care, whether it be, community hospitals or other aspects that may be, sort of have the potential to continue to sort of muck up the system in terms of throughput. I think workforce has to be included in our analysis of that. I think that's the biggest stress that is coming up the works now. And obviously, we need to think more effectively about strategies to overcome some of the workforce challenges and, creating the right pipelines for various health-related careers. David, when you looked back on 2022, they're all great recommendations. It really comes down to where's the political will to sort of implement these. And, maybe I've been sitting on the commission too long, but every year we've put forward some strong recommendations relative to what would make our work more effective. But we haven't seen those work their way into legislative action. So is there more we could be doing to try to move these recommendations forward in a way rather than just, publishing them again in a report? I'll leave it at that.
Yeah, thank you, Commissioner. And just to quickly respond, when I looked at the list of recommendations from last year, in terms of new areas, workforce jumped out to me. It was not one of our core recommendations last year. And the rationale for that was because we were working on a workforce report, and we're released that report earlier this year. We had an incredible workforce summit. But I do think in this year's recommendations, I would recommend that we have a recommendation focused on workforce that draws from both some of our recommendations in that report, as well as from some of our other work, recognizing that is just such an important topic in the healthcare community. If people looked at our recommendations from 2023 and didn't see anything about workforce, I think they would say we are not reading the moment. And so I would recommend that be an area we think about making its own standalone area. And then to the second point, I agree with you, Commissioner, around, many of these recommendations are things, some of these recommendations are things that do require legislative change, and that is a long process, and one that cannot always be predicted in terms of the outcomes. And so I would love to think with the board and the commissioners about either included within this report or as a companion that we work on with the report. What is our work plan at the HPC? What can we do, even outside of legislative activity or statutory changes, to advance and work towards each one of these recommendations? Some of them I think will have more levers than others, but I think it would be worthwhile to maybe articulate what that plan is, so it doesn't feel like we're just waiting on someone else to act. And I don't think that has been our history, but we could think about how we communicate that and track that and hold ourselves more accountable to that. So interested in thoughts on that topic as well, and where that kind of sits either within the report or as a companion kind of work plan. I haven't landed a thought on that. But Deb, Commissioner Chair Defoe, sorry. I know that's an area where you have also wanted to maybe have us think a little bit creatively or differently this year.
Yeah, I feel that in every one of these areas, there's much we have done and much we can continue to do to advance the goal. And the more we can be clearer about that action for each one of these, and then as David said, be specific about where we're making a recommendation that would require legislative change, how would that enhance our current ability to affect that recommendation, so that we're really more focused on being able to say, here's what we can do, here's what would require further legislation, and here's what the likely impact of that could be. So I think it would be very helpful for us to think more about that as we make these recommendations, as David said. Commissioner Mastrogiovanni?
Thank you. I certainly agree with what you said and also David's comments and Martin's comments. I think one of the things that we can do once we come up with a list is, number one, we need a specific game plan with a timeline. And at our board meetings, we should review that to see where we stand based upon what the expectations are, what we're trying to get done, and what roadblocks we may be running into. And that's something that we should discuss. And I think that would be a big change to potentially actually achieving some of those goals and having an impact, a greater impact, I should say. Thank you.
Thank you. Good point. Other thoughts? Commissioner Castillo?
I always bring it back to inequities, and I think that looking at outcomes is important. I think if we can say that the amount of healthcare, the cost of healthcare is incredibly expensive, and we want to bring it down. But I also want to be able to say, well, is that amount, that cost, does it translate to changing inequities? Are those outcomes much better? I think for us here in Worcester, we look at trying to find the data of what's happening here, and then sort of figuring out even in the community. I think we always need legislative thoughts, but I think the community can solve it if the community understands where they stand. Hospitals will look at that and be able to say, we're doing terribly in this area. Maybe what are the things that we need to do? What are the trends? And we need to follow that. So I don't know if we can do something similar, but looking at what are the outcomes, I think are incredibly important. And I've mentioned this to you before, David, I've always just want to bring it up that we look at when we talk about the social determinants, that the cost of homelessness, the cost of the opioid epidemic, where does that tie into this process? And again, the equity piece with the opioid epidemic is also important. How does that tie in with the cost of what's happening? And certainly our outcomes in that isn't very good.
Thank you.
Yeah, thank you for both the last two comments, and Ron for your support and kind of helping us think through how we track and hold ourselves accountable to the work plan. And Commissioner, on these important equity issues, and as you said, having an outcomes focused lens that we bring to our work. And I did want to just piggyback on the last thing you said, which is around opioid use disorder and medication-assisted treatment. And I think where we know from the data that there is, an increasing prevalence in Black and Hispanic communities of the opioid epidemic. This is an equity issue as well. I think we know more about that, in the last few years. And I think that could be something we weave a little bit more clearly into our recommendations.
One other thought for us to consider as far as getting, as far as a new recommendation, is that we track and report a lot of data around affordability. And I think to Commissioner Welch's earlier point around how is that embedded in our general reporting and how is that accessible to the public, I think it may be useful for us to consider creating an affordability index that takes into account different aspects of affordability for the different parts of our citizenry that were reported on earlier in the dashboard, and frame it in a way that's easier to understand and to track and look at. So I would just open that up for any other comments from other commissioners. Do you feel an affordability index would be useful in addition, of course, to the cost trend benchmark?
I think that's a really good idea, Deb. That's kind of what I was grappling at when I was looking at the dashboard. Like, what does that mean to the average person? I'm in the business, so I kind of like this stuff, but that's sort of what I was getting at. I think that's a really I think they're always tricky and, what
Yeah.
measures, indexes are hard, but I think it also gives us, it could be mild, medium, hot or something. It doesn't have to be, we can sort of make sure people are in the ballpark on things. I think it's a really good idea. And it could include a market basket of services that people purchase. People aren't in hospital beds all the time. And a lot of our work seems to focus that way.
Yes. Commissioner Blakeney?
Thank you. Madam Chair, I love the suggestion. I remember very distinctly going back to the cost trends hearing and David Auerbach pointing out that at the rate of insurance prices and the index that we were looking at, that it would take 50% of an LPN salary to pay for the health insurance. And that has stuck with me. That has been such a profound statement. Any data point that we can identify that drives home the individual impact, I think is powerful. I think it makes it relevant to people who otherwise might not understand or appreciate the degree of relevance that it actually has. So I would love to see us figure out how to be able to do something like that.
Thank you. Other comments, thoughts, recommendations about areas we could deprioritize or change or expand? And certainly keep ideas coming if you're reflecting on the meeting and you would like to provide some more input on this topic.
Well, I will just mention one, Madam Chair, that I had on my little back of the envelope list, which is around prior authorization. That's a topic that we have spent some time in the past year working on different projects on around the potential for automation of prior authorization and even beyond that for potential improvements in terms of simplification and standardization. We had administrative complexity as one of our sub-recommendations last year. But that may be an area where we could pull that out as its own recommendation to have perhaps some more specific things to say in terms of policy recommendations. So I will throw that one out on the table as well.
Yeah, terrific.
Great. Thank you, commissioners, for this conversation.
Yes.
Next slide. So as I said at the beginning, we're going to be back with a draft over the summer to share with all of you. I very much look forward to your input on these recommendations in particular, as well as the full cost trends report, and would hope to have a few conversations with many of you to follow up on the great comments here today. We do hope to be able to release the report at the September board meeting. So definitely a busy summer ahead of us still. So just moving through the agenda here, we're going to shift gears a little bit and wanted to provide an update to the board on the Mass General Brigham Performance Improvement Plan. We have not yet provided a public update on the PIP and just recently received the first public implementation report from MGB about their progress on the performance improvement plan, and wanted to share key findings with you commissioners from that public report that they just submitted. So to lead us through this conversation, I'll turn it over to Kara Vidal.
Great, thank you so much. So nice to be here in person with some of you today. All right, so before we dive into the update that MGB recently provided to us, just wanted to do a brief recap of timeline and how we got here. So as you'll recall, the board voted to require a PIP from Mass General Brigham in January of 2022. Mass General submitted a preliminary proposal in May of that year, and they submitted a revised proposal in September, which the board approved. MGB's approved PIP aims to save $176.3 million over the 18-month implementation period, using a combination of 10 different strategies in 3 different categories. You can see those categories on the right-hand side of the slide. You can see there's actually a fourth category listed at the bottom, accountability through value-based care. They didn't quantify any specific savings there. So the ones we're tracking on here are in those first three categories of price reductions, reducing utilization, and shifting care to lower cost sites. You may notice that the numbers on the right-hand side here are different from what you might recall from the September board meeting. That is because when the PIP was being developed, Mass General Brigham reported their savings on an annual basis. That was really helpful at the time because we were trying to assess the appropriateness of the savings target, and we were often comparing to their annual performance, their TME growth, their financial impact. All that was done on an annual basis. Moving forward, I expect they will continue to report on the all-in 18-month basis. So all of these numbers track. There hasn't been any change in expected savings. We're just now looking at them for the 18-month total instead of on an annual basis. So MGB began implementing their PIP immediately after approval. So that was October 1st of 2022. That means the PIP will run through the end of March 2024. And it also means that because we're now in July, they're halfway done. We hit the halfway mark. I know time really flies, went quickly. However, because of known data lags, the report that they have submitted and that we'll walk through today covers the first 6 months of implementation, October 1st through the end of March 2023. In addition to the public report, which is available on our website, everyone should feel free to take a look. MGB has also submitted more detailed confidential reports to us, which we have reviewed very closely and have discussed with them as well. Obviously won't be able to share that information publicly today. And it also means that if you ask me a question, I'll do my best to answer it, but I'm also aware of the fact that I know things that I cannot say. So I'll do my best there. Okay. As a reminder, at the conclusion of the PIP, the HPC has to determine whether the PIP was successful. There are factors in the PIP regulation that the HPC can consider. Those are listed on the slide here. And they include things like whether MGB successfully addresses concerns about its cost growth, whether they fully implement their proposed strategies, questions around sustainability, the impact of any events outside of their control on their results, and other factors that the commission can determine to be relevant. If the board finds that the PIP was successful, the PIP will conclude and MGB's name will be removed from the HPC's website. If not, the board has three options. You can require a new PIP. You could require an extension of the timeline with potential amendments to the PIP, or you could waive the requirement to require a PIP. So that's where we're headed with all of this. Okay, so turning now to what MGB has reported on their progress to date. So overall, after 6 months of implementation, MGB is reporting that they have saved $45.3 million in savings. That's about 25% of their total savings goal. We're about a third of the way through the time. We're about 25% through the savings target, but they did not anticipate that savings would be broken up equally month over month. There were some interventions that started later, so they report still being on track to meet their total savings target of $176.3 million. They have reported that their savings are slightly ahead of expectations for a few categories, specifically savings associated with their integrated care management program, and their pricing adjustments are slightly ahead of what they anticipated. On some categories, they're slightly behind what they anticipated, specifically their imaging utilization and their home hospital strategies. It is worth noting that for the strategies where they're slightly ahead, particularly the pricing adjustments, those are much larger categories of savings overall. So they're reporting being ahead on the bulk of the savings. Also should know that MGB has an ability under our regulation to propose amendments to the PIP should they feel it necessary. They haven't proposed any amendments to date. Thank you. Oh, other way. Great. Oh, we're back at the beginning. Okay, here we go. Thank you. Okay, so the next 3 slides we have here will go through the 3 categories of savings and show you what MGB is reporting in terms of expected savings and actual savings through the first 6 months. So here we have the pricing concessions slide. There are 4 specific interventions that MGB is implementing here. You can see that the total savings target for this slate of interventions is $125 million over the 18-month time period. That's about 70% of their total anticipated savings, by far the largest category. They are reporting that they've saved just over $25 million. I'm sorry, they are reporting that they anticipated saving just over $25 million. Their actual savings just slightly ahead of that. They are reporting saving $27.6 million in the first 6 months here. If you look strategy by strategy, you can see that the first 3 interventions, which are the ones that have started, are all, according to MGB, tracking slightly ahead of expectations. The 4th strategy here, other insurance product, didn't start until July 1st, so just 2 weeks ago. So no savings there yet. So starting from the top, we have outpatient rates. This is the strategy under which MGB is making pricing adjustments with certain commercial payers for its AMC outpatient services. Their total savings target is $86.4 million. It's about 50% of the savings in the entire PIP in one strategy. They were anticipating saving about $15.6 million. And as you can see, they're slightly ahead. They're reporting $16 million. In terms of the second one, we have Mass General Waltham rates. Under this strategy, MGB is converting the pricing at its outpatient location in Waltham from an AMC rate schedule to a community hospital rate schedule. Total savings are $19.1 million, or about 11% of the total savings under the PIP. And here also you can see their reporting being about $1.5 million ahead of expectations. And then connector care rates. This is a strategy in which they're reducing rates for members of MGB health plan with connector care products. That's a total of almost $18 million in savings, or 10% of the total. And here they're also reporting being slightly ahead of schedule. And I should note that on this strategy, they had a data lag. So they have only reported savings for the first 3 months of the 6 months here. So maybe even more ahead of schedule when they get the next quarter's worth of data. So overall, about $2.2 million, according to MGB, ahead of where they expected to be for the first 6 months. All right, the next category is reducing utilization. This is also comprised of 4 individual interventions for a total of $44.4 million in total savings over the course of the PIP. So that's about 25% of total savings included across these 4 strategies. Because of data lags, we only have information on the first strategy here, the Integrated Care Management Program, and the 4th, which is their imaging utilization strategy. We don't have data yet on their SNF utilization reduction or their MGB health plan utilization management savings. So we'll focus on the 2 we do have data for. So for the Integrated Care Management Program, under this strategy, MGB reduces spending for high-risk patients by enrolling them in its care management program. The total savings here, about $23 million. They anticipated saving about $13.2 million in the first 6 months. They're a little bit ahead of where they anticipated being here. And then on the imaging utilization piece, a smaller strategy here. This is $6.5 million in total savings, about 3.5% of the total. And here you can see they are slightly below where they anticipated being at this time. That, according to MGB, is because they had a few delays launching some of these strategies, but they are now fully launched. So we'll be monitoring this closely, but that is the explanation for why that one was slightly below expectations. And then our final category here is shifting care to lower cost sites. There are 2 strategies. in this slate of interventions, their home hospital strategy and their virtual care strategy. Across the two, they're anticipating saving about $7 million across the 18 months of the PIP. So obviously much smaller than the first two categories that we looked at. The home hospital strategy is their plan to provide hospital level care in patients' homes at a discounted rate from what they would receive if the patients were treated in the hospital. They're anticipating total savings of 1.9 million. You can see they are reporting being slightly under expectations here. They noted in their public report that this is due to fewer admissions than they had projected at the time, related to some staffing challenges on their end. So another piece we'll be tracking closely with them. And then their virtual care strategy, in which they generate savings by providing telehealth specialty care at a discounted rate from what it would be in person. Here, that's a total of 5.1 million over the course of the PIP, and they're reporting being slightly above expectations due to higher than anticipated volume of telehealth specialty care. So our next steps here, our team has been in regular contact with MGB throughout the course of the PIP, both for mandatory quarterly check-ins, the next of which will occur in August, as well as for several one-off conversations and discussions. The next quarterly check-in in August will cover April through June. That will not be accompanied by a public report. The next public report will be due the quarter after that. So after September, and we would anticipate making another public update at that time. And I will do my best to answer any questions.
Excellent, thank you. Any questions? Any commissioner?
Scared everyone off.
Commissioner Mastro Giovanni?
At one point that I think is important to highlight for everybody is I think they're doing a good job. They're a little behind, but they feel comfortable in terms of meeting the number, which is a big plus. How are we verifying the numbers that we see? Right now, they're like 10 million behind, right? If you're breaking it down, but again, if they feel comfortable with that, that's great. I think that's a big plus. But I think we need to let the public know how we're verifying the numbers. Are we using third-party accounting firms? How are we doing that?
That's a great question. So as I said, the first and most important piece is that we have much more detailed numbers, including their methodology for how they're performing these calculations that we have looked at and gone over with them, have certainly raised some questions for them about, for example, what the appropriate baseline might be in a calculation or why something is behind schedule in a certain piece. We do have expert teams also who will assist us with our evaluation. We have accounting experts, care delivery experts, actuaries, economic consultants. So a full slate of experts to help assist in that regard. And I do anticipate that we will do sort of a more fulsome review of what we're finding as we move further along in this process. I think we're still, although we're halfway through, we're really only looking at the first 6 months. Several interventions didn't begin until the second quarter. So I think we're still back and forth on exactly what those calculations should include or shouldn't include, inclusion, exclusion, that sort of thing.
Excellent.
But to put a fine point on it, we will be doing our own validation and evaluation of the savings targets to aid in the commission's assessment of whether or not the PIP was successful at the end of the day.
That's right.
And at our future meetings, we'll be able to report more fully on that assessment. Great.
Yes.
Other questions? Any other comments?
I just like to say, I just wanted to share that the tone and tenor of the conversations with MGB has been extremely constructive and positive. They have been made themselves available multiple different times from a senior leadership to a program expertise level to go through and answer our questions and provide information to us, and have stated repeatedly a commitment to make sure that this PIP is successful and to hit their savings targets. So want to thank them for their leadership and continuing to push forward on this. We will continue to do our role, which will be to monitor and evaluate, but just to report that the conversations have been very constructive so far.
Excellent. Good.
Thank
Thanks
you.
so much. We'll now turn to our last item in the agenda, which is our executive director's report.
Great. Thank you, Commissioners. So we have a number of quick topics here in the Executive Director's report before we'll take a short break and then we'll go into our executive session. So the first one does require a vote. So I'm here today to present on our fiscal year 2024 budget proposal. So first, I'm just going to provide a very quick summary of our budget performance in last fiscal year 2023, which ended just a few weeks ago on June 30th. And then I'll present the proposal for the next year's budget. First, just by way of background, when the HPC was originally established, we were funded through a one-time source of funding from the legislature that was deposited into a set of trust funds. But beginning in 2017, the annual budget for the Health Policy Commission is set in the state budget. And that state budget is, of course, negotiated and signed by the legislature and the governor. So we have a specific line item that is included within that state budget every year, $1,450, $1,200. The amount that is appropriated to the Health Policy Commission, importantly, we then assess acute care hospitals, ambulatory surgery centers, and health insurance companies for that full amount that's included within the state budget. And we deposit those funds back into the state's general fund. This is a very similar assessed funding mechanism that the Center for Health Information and Analysis relies on as well. The point here is that we are essentially considered a held harmless account for the state budget. While we do get an appropriation, we then deposit that exact same amount back into the general fund. So last year, the legislature appropriated $11.1 million for the HPC's operations, and that aligned with what our request had been at the time for a maintenance level of budget. So last fiscal year, on the next slide, we project coming in slightly below our available funds for the year. You can see on the left-hand side the total 11.1 and what we're today projecting for our final expenditures, with a very modest surplus at the end of the year. A lot of our work can be unpredictable in terms of the timing of the work, when we will receive material change notices, the potential for cost and market impact reviews, the timing of drug referrals, where we are in the performance improvement plan process, as well as the timing of our grant and investment programs, which also are funded in part through our line items, all can lead to a great deal of uncertainty throughout the year. And so that has resulted in kind of tight fiscal management over the years, and always a little bit of surplus at the end of the year, just given that unpredictability. But I would say in this last fiscal year, we absolutely did a really superb job in terms of managing our expenditures to the budget. On the next slide, you can quickly just see in terms of major categories where the HPC spends its funds. The biggest portion of the pie in dark blue is payroll and staff. The second biggest portion of the pie is in the light blue. That is our consultants and professional contractors that we work with. And then the other portions of the pie are our general IT and operational expenses at the agency. On the next slide, you can see this again is the last fiscal year, what we had projected spending versus our actual spending. And you can see in all cases, we are close to 98%, 99% of what we had projected for each of these major categories. So moving into the next fiscal year 24, which began on July 1st. We first requested an amount from the governor and from the legislature of $11.4 million. That represents a 2.9% increase from last fiscal year. And what this assumes is a funding for a maintenance of effort budget. And what I mean by that is that this amount will allow and support the HPC to continue to have the annualized costs for staff and professional services to meet our ongoing responsibilities and priorities. Again, I would say in part because we are an assessed account and our account is funded by the healthcare industry, We try to be very conservative in our budgeting approach and our budgeting asks. As you can see, a 2.9% increase is below the benchmark and certainly below the growth in the overall state budget. And we also know that there can be unknowns in any given year. I would note the most important point I would say on this slide is the final point, which is that this budget does not assume that we will have new additional responsibilities through new legislation. Should new legislation pass this session, which we are very hopeful that it does, we will engage with the Ways and Means Committees and Administration and Finance about what additional resources will be necessary to meet those obligations. So that was our request of 11.4. On the next slide, we're very pleased to be supported across all three branches of government at that exact amount. And so while today we do not yet have a final state budget for fiscal year 24, I felt it was comfortable to come to you with this proposal, recognizing that all three branches did agree on our budgetary amount. If for some reason the final budget does not include some different amount, I would come back to the board and present a modified budget for your approval. So working off of that 11.4, just want to also mention in terms of any new responsibilities that were included within the two budgets that the House and the Senate passed. Not very much this particular year. In past years, we've gotten new mandates and studies and task forces that we've been charged with. This year, were mentioned in two different outside sections within the Senate budget. These outside sections were not included in the House budget, so we do not yet know if they will be included in the final version of the budget. But here, both of these are studies that will be led by our sister agencies at UHHS and DPH, and the legislative language directs us to help support these activities. Should these outside sections be included in the final budget, I'm confident nonetheless that we can find the resources to be able to support our sister agencies in this work. The next slide, again, is this pie chart showing the recommendation for the next fiscal year in terms of the distribution of funds. You can see, and you'll see even more clearly on the next slide, that whatever new funding that we've received through this budget, we're really focusing that new resources into staff and the payroll account, and these other accounts are generally held pretty steady. So the next slide shows us a little bit more detail where we show the difference between last fiscal year and this fiscal year by these major categories and what the major differences are. The increase in payroll and taxes is really a reflection of a couple of different dynamics. One is the need that we've had to make appropriate salary adjustments and cost of living adjustments for our staff. This is a very competitive hiring market. And that has been recognized by the executive branch as well, which has made some notable adjustments to salary for both union and management across the executive branch. We have also made some necessary adjustments. We had some turnover last year, so we still have some backfills that we are hoping to fill, probably most notably our communications director. And with the increase in the budget, we do think we'll be able to support a very small number, 2 to 3 of new staff. So all of those dynamics contribute to the slightly higher payroll and expenses. It's really just an annualized cost of doing business, to be blunt. And there is a little bit of a trade-off between payroll and taxes and consultants and contractors, where we're able to shift some of our consulting costs onto staff, given our growing expertise in a number of areas. As you can see on the next slide, despite having grown in responsibilities and impact over the last many years, our staffing levels have stayed very constant. And so we have continued to do more and more and more with just about the same amount of incredibly talented expert staff at the HPC. So really, not much more notable to say about this budget proposal. As I said, really a maintenance budget, really just accounting for the annualized cost of salary and staff. And we're really pleased to be supported by all three branches. And so at this moment, I'll open it up for conversations and questions, and would just note that I did present this budget proposal in even more depth to the Administration and Finance Committee earlier this week. And so they may want to chime in as well.
Yeah, perfect. And that committee consists of Commissioners Hout, Cohen, Mastro Giovanni, Quasnick, and myself, just for the information of the other commissioners. So we did have the opportunity, as David said, to go through this in detail with him and to understand some of the decisions that were made in constructing the budget for the coming year. Yeah.
And can I just say, I think David did a thorough job. I think everything was incredibly reasonable. And I think, speaking on behalf of the committee, that we felt very comfortable with the presentation.
You're here. Second that. Any questions? Hearing none, can I ask you to go through the vote?
Absolutely. Can I get a motion?
So moved.
Thank you. And a second?
Seconded.
Thank you. I'll start with you, Chair DeVoe.
Approved.
Vice Chair Cohen,
Approved?
Commissioner Blakeney,
Approve.
Commissioner Caskill,
Approved.
Commissioner Haupt. Approved. Commissioner Master Giovanni,
Approved.
Commissioner Quasnick,
Approved.
and Secretary Walsh.
Approved.
Thank you. Motion passes.
Thanks so much. We'll continue with the report.
Great. So the next topic is our regular meeting agenda on notices of material change. I'm going to turn it right over to Sasha to just update us on what's happened since the last board meeting.
Thank you, David. I'll endeavor to keep this brief. Since 2013, the Health Policy Commission has received notice of 151 provider transactions with formations of contracting entities, the most frequent, as you can see on this slide. On the next slide, you can see that since our last meeting, we've received we've moved to close out material change notice reviews for 3 proposed transactions. First was the proposed clinical affiliation between Emergency Physician Associates of Massachusetts, St. Vincent Hospital and Metro West Medical Center. St. Vincent Metro West, of course, are owned by Tenet Healthcare Corporation, which is a national for-profit system. EPA, the physicians, is an affiliate of Team Health, which is a national healthcare staffing and management company. Under the proposed transaction, EPA would become the provider of emergency department services for both St. Vincent and Metro West. In our preliminary examination, we found limited potential for impacts on spending and market function as a result of the transaction. Team Health fundamentally has a limited market presence in Massachusetts, and we expect that that will limit its ability to negotiate higher reimbursement rates as compared to the physician groups that were staffing the Tenet hospital EDs prior to the transaction. Second transaction, the proposed employment of the emergency medicine clinicians of Newton Wellesley emergency medical specialists by Mass General Brigham. The EMS group is a private medical group specializing in emergency medicine that staffs the emergency department at Newton Wellesley Hospital, owned by MGB. Under the affiliation, the emergency medicine physicians and advanced practice providers would become employed by MGB's community physician organization. They'd continue to provide emergency medicine services at Newton Wellesley. In our preliminary examination, again, we found limited potential for spending and market impacts. The emergency physicians already participated in MGB payer contracts, and therefore our expectation is that the total impact on spending from any rate changes due to employment would be likely to be small. Third transaction is the proposed clinical affiliation between 4 Beth Israel Lahey Health, BILH affiliated entities, BIDMC, Harvard Medical Faculty Physicians, Mount Auburn Hospital, and Cambridge Health Alliance. BIDMIC, HMFP, and Mount Auburn are all corporate affiliates of BILH. CHA, as you'll recall, is a contracting affiliate. The proposal is to expand on a long-standing clinical affiliation between BIDMIC, HMFP, and CHA to include Mount Auburn for coordination of healthcare services, preferred provider relationship for referrals between CHA and Mount Auburn, and joint development of clinical programs. And here again, we found limited scope for spending and market impacts. To the extent that the affiliation results in more CHA patients using Mount Auburn for tertiary services rather than BIDMIC or other Boston area AMCs, we'd actually expect some savings based on current payer rates. Total patient volume that's likely to be involved is likely to be small. So fundamentally, relatively small impact. And for all three of these transactions, we did not review evidence indicating that any of them were likely to negatively impact clinical quality or access to care. So that is the update on these three. We have no current notices under review.
Great, thank you, Sasha. Any questions or comments? Great, seeing none. I'm going to move on to the next topic, but we're actually going to hold on this topic. So we wanted to provide an update to the board and to the public around our ongoing commitment to embedding health equity into all the work of the HPC. We have, over the last few years, used the July meeting as an opportunity to provide an annual kind of update on the agency's activities and our progress in this commitment. I think this is such an important topic. I really don't want to gloss over it here in just a few minutes. So if it's all right with you, Chair DeVoe, I would propose that we hold this conversation for when we have a little bit more time at the next board meeting and give it the time and attention it deserves.
Sure, that's great.
Thank you. And then we'll turn it now over to General Counsel Lois Johnson for a brief update on one of our responsibilities under the Mental Health ABC Act.
That's right. Good afternoon, commissioners. As David mentioned, one of our responsibilities in that new mental health law was for the HPC to develop a standard release form for exchanging confidential mental health and SUD information. This has been an issue of consternation to many providers because of the different privacy regimes for regular or medical patient information and substance use disorder information, which is treated with a higher level of security. The law required the HPC to develop the standard form and also to convene an advisory group of different perspectives to develop that form. We wanted to provide an update on that process. The federal government that is in charge of promulgating regulations under the SUD, the 42 CFR Part 2, which is the privacy regulation governing SUD treatment records, issued a notice of proposed rulemaking. And this is a significant development because it would propose aligning very closely the HIPAA rules for medical records with the SUD treatment rules, which is a good development. However, that's just a notice of proposed rulemaking. That is not a final rule, but we want to let that process play out. So far, there haven't been any indications of a timeline. Comments have been received, but given the implications of that, and because we think that moves the ball forward in terms of alignment, our recommendation is that we're pausing the timeline for this process. And we've been in touch with members of the stakeholder group who would form the advisory committee to let them know that we're going to sort of hold, it makes sense to hold on this process until that we get some more information about the final rule. Great. Any concerns about that or questions from commissioners? Good.
Great. Thank you, Lois. And then the final update that I wanted to provide to the board and to the public is around the HPC's participation in Academy Health. Academy Health is an internationally renowned nonprofit organization focused on the discovery and dissemination of timely and relevant research-based strategies to improve health and health care. This research organization holds an annual meeting every year, which is really a preeminent opportunity for researchers and experts to meet and to move research into action. As part of this annual meeting, they have a very competitive process where researchers can submit proposed research to be presented either through a poster session or through a public podium session. And the HPC has participated in this annual meeting in just about every year over the past 10 years and submitted proposals for presentation. Over the years, we've been very successful in having our research be selected and highlighted at this annual meeting. And also it is a great opportunity for us to expand our network of like-minded researchers and experts from really across the country and the world. Just wanted to highlight that this year was a little bit of a special year. We submitted many different applications, but we're pleased to have 7 posters of work conducted by staff here at the HPC and 2 podium presentations accepted by the conference. The podium presentations in particular have a very high bar. But the most important thing here is that one of the posters that was selected to be one of the best in its category, and then ultimately was voted on and was selected as the very best poster of the entire conference in competition with thousands of other posters from research institutions, well-known named research institutions from across the country and the world. And our poster was selected as best in show. So a real testament to the staff at the HPC, who are world-class researchers in their own right, and a great recognition for our work, and want to congratulate the authors of this particular poster. We'll find a place somewhere in the office to display it in perpetuity, and wanted to share that great honor with the board and with the public. And with that, I think we have come to the end of the agenda.
Thank you so much. So the board is now going to vote to go into a confidential executive session. We're not going to reconvene in a public meeting, so the public meeting will now be adjourned. And if you could take us through the vote.
Great, thank you. Can I get a motion? And second?
Second.
Thank you. Chair DeVoe, we'll start with you.
Approved.
Vice Chair Cohen,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Kwasnick.
Aye.
And Secretary Walsh. Commissioner Sung, would you care to vote on behalf of Secretary Walsh?
Aye.
Thank you. All right, so we will convene in an executive session. Thank you.